Hi, I'm Marvin Matevich. I'm on the staff of Cleveland Clinic, and we're fortunate today to have Mark Corson here today to speak with us about metabolic considerations in individuals with autism spectrum disorders. Dr. Corson received full pediatric training and received his medical genetics training through the Boston Children's Hospital and Harvard Medical Program, and is currently chief of the metabolism service at Tufts Medical Center, Floating Hospital for Children. In terms of today's session, we have a number of learning objectives. First, we'd like viewers of this webinar to appreciate that a number of metabolic disorders can manifest as autism or have autistic features in the individuals with those metabolic disorders. Second, we'd like viewers of this webinar to appreciate that there are some specific genetic metabolic disorders that can have autism as an important feature of the clinical phenotype. Third, we would like viewers to come away from seeing this webinar with an appreciation of the clinical recognition of important signs and symptoms for metabolic disorders in persons with autism. And finally, we'd like viewers to recognize when it may be appropriate to refer an individual with autism to a specialist in clinical metabolism, or how to begin an appropriate diagnostic evaluation themselves. By posing to you two brief but hypothetical but very realistic clinical cases and hear your thoughts on each of them as an expert in metabolism in terms of what elements of the histories and physical examinations of these two cases might arouse concern for an underlying metabolic disorder and how it could be approached. The first case involves a 3.5-year-old girl who has both global developmental delays and autism, and she's referred to your clinic for genetic and metabolic diagnostic evaluation. And at the present time, this girl has a few word vocabulary and she can point, but her expressive language function has regressed since she was about 2 years old, and her receptive language function, while not formally studied, is still at a 2-year-old level. She's hyperactive, and she's often inattentive and impulsive. Her gross motor development seems unremarkable, and her past medical history is notable for numerous bouts of otitis media and upper respiratory tract infections, and she's frequently at her PCP's office for care of those particular issues. She also has a history of significant sleep difficulty, both in getting to sleep and in staying asleep. This child's family history is unremarkable. She has a single sibling, a developmentally and neurologically normal 6-year-old brother who's been in good health and has normal growth. And both her parents are healthy and they're unrelated, and there's no one in the extended kindred going out several generations on either side who has either intellectual disability, other developmental delays, or autism. And when you examine this child, Dr. Corson, you find that she has mild macrocephaly with a head circumference at the 3rd standard deviation above the mean. She has mild short stature, a lumbar lordosis, and the suggestion of the beginning of contractures of her fingers, although you could passively extend her fingers to their full range of motion, passively. On neurological examination, she's found to have poor eye contact, marked hyperactivity, extremely poor social interaction with intermittent aggressive behaviors, and she's had a limited diagnostic evaluation before she comes to you but she does meet criteria for autism spectrum disorder on formal developmental assessment when she was 3 years old using the ADIR and ADAS tools. And so, Dr. Corson, I'd like to ask you, based on hearing this précis, what your diagnostic considerations might be, what elements of her clinical history, what elements of her physical examination raise a question of the possibility of an underlying genetic metabolic process that could be causally related to her autism, and what your suggestions might be in terms of further diagnostic evaluation.
Okay. Well, you know, based on, one might look at this case and start saying things like, well, autistic children are developmentally delayed. They often have regressive episodes. They are often poor sleepers. They may have aggressive behavior, and try to clump all that together and just say this is just autism. But if you pay attention, many children with autism are not globally delayed. So there is one point. The regression within autism generally happens before 2 or 3 years of age. But here's a child who has regressed since then, and gross motor development is unremarkable. The frequent bouts of otitis media and upper respiratory tract infections, is that related to the sleep difficulty? In other words, is there a problem with any sort of obstructive component to sleep, which might result in also in problems with drainage from the middle ear, in which case you get recurrent otitis media. It would be useful to find out if this patient snores. And if this patient, I mean, the patient clearly has problems staying asleep, I would bet that she also probably has tosses and turns a lot during the day, during the night. The mild macrocephaly, first question is, are the parents macrocephalic? But if this is an isolated mild macrocephaly, that's a concern. Her short stature and her lumbar lordosis are concerned, and what appear to be contractures of her fingers. So putting all this together for me, this sounds a little bit like the progression of a storage disorder, of a patient with who is depositing storage material in subcutaneous tissues.
Do you mean like a lysosomal storage disorder?
Correct, like a lysosomal storage disorder that is interfering with growth. So it can certainly result in short stature. You start seeing bony abnormalities like a lumbar lordosis. You get deposition in the joints, or you get improper, restricted movement, and often those patients become more macrocephalic over time. Because of the deposition in the soft tissues, they often have problems with sleep disorders. They snore, they're restless, they classically have recurrent ear infections over and over again, and have very significant obstructive sleep apnea. The specific, now, nothing is mentioned about whether or not the patient has any a coarse appearance to the face. And sometimes that might be difficult to ascertain if you're not trained to know what a coarse appearing face looks like. But one lysosomal storage disease, one mucopolysaccharidosis, Sanfilippo, or type 3 mucopolysaccharidosis, may not have much in the way of coarse appearing face at all, but just some of these other features which presents classically early on with behavioral, developmental issues, impulsivity, You might see aggressive behavior often develops, and the neurologic decline that is classic for the mucopolysaccharidoses may not occur until ages 7, 8, 9, 10. So at this age, at 3.5, you might not see those neurologic findings, but you'll see these other features. So that's the top thing on my differential diagnosis would be a lysosomal storage disease. And the easiest way of just assessing that is urine for glycosaminoglycans, looking for an abnormality in accumulation of a specific metabolite, heparin sulfate.
So it would seem that this case would abide by your general rule that you've stated several times, that the individual here with autism has unexplained abnormalities in multiple organ systems with macrocephaly, short stature, developmental and neurological problems that are not typical of so-called classic autism or typical autism.
That is correct.
And that would serve you as a red flag to say perhaps there's an underlying metabolic process. And in this case, you're saying potentially a lysosomal mucopolysaccharide storage process.
That's correct. Now, so that's on the top of my differential diagnosis. But if you're looking to develop a more complete differential diagnosis, then certainly with global developmental delays is a very broad diagnosis. Issues with sleep difficulties, well, a subset of patients with mitochondrial disease get very significant, have very significant sleep problems. Here's a patient who has normal gross motor development, but very significant language problems. Disorders of creatine metabolism should be considered in that kind of situation, even if they don't have seizures. Mild short stature, again, can be seen with mitochondrial disease. Macrocephaly, not typical for mitochondrial disease. And so, there's not a good fit with given all these features for others, but I guess if you neglect certain aspects of the history, if there's another reason for the short stature or the lumbar lordosis, if that may run in the family in itself, then there are other disorders that one could consider. Anything from the more common, some sort of chronic organic acidemia. You could see disorders of purine or pyrimidine metabolism, disorders of glycosylation could contain these kinds of features, and there's other less common causes, but would fit in. This is
so perhaps with a tincture of time, the full natural history of the condition could evolve and other clues may become apparent. But at this point in time, the largest category that's the single best fit would be a lysosomal storage process, but some other categories need to be kept in mind.
That is correct.
Let's move on to the second case of a person with autism. In this situation, it's a 13-year-old male who's referred to your clinic for genetic and metabolic diagnostic evaluation. And this boy's parents reported that in addition to his diagnosis of autism spectrum disorder, he also has attention deficit hyperactivity disorder, excessive fatigability, and exercise intolerance, and clumsiness. The past medical history of this boy is notable for mild delays in acquisition of gross motor milestones and moderate hypotonia during infancy and early childhood. As a young child, he was very intolerant of changes in routine, and he'd have tantrums if there were any deviations from routine. He also has a history of fasting intolerance and needs to eat shortly after awakening in the morning, and he needs to snack multiple times during the day and much more often than age-matched peers. Some of his developmental skills have regressed after illnesses when he was between the ages of 2 and 5 years old, including some of his expressive language skills and problem-solving skills, but these later returned, and he's now felt at 13 years old to be cognitively normal, but nonetheless has atypical social interactions and needs support because of those delays that he has in that realm. He has difficulty at the present time in maintaining conversation with others, and he's unable to maintain friendships. He doesn't seem to share interests, and he has difficulty communicating with his peers. He also has a restricted range of interests, and he perseverates on, for example, airplanes and rockets. He continues to have a very strong need for routine, and on his general physical exam and on his general neurological exam, he's found to have mild diffuse hypotonia and some gross motor clumsiness, along with the atypical social communication and interaction. And he's very tired during the exam. So given this past history and the recent physical exam findings, what might be some important diagnostic considerations? And what, if anything, might suggest an underlying genetic metabolic process that could be related to the autism in this case?
So it's clear to understand, based on the patient's behavior, patient's interaction with peers, that is social interaction, communication skills. It's clear to understand why the patient is carrying a diagnosis of autism. But the things that stand out are the things like the excessive fatigability and exercise intolerance. Patients with autism are usually very active and they don't stop. So again, the child who fatigues, stops, or even goes to sleep is a big concern. The fact that the mild delays and the mild delays in acquisition of gross motor milestones and the moderate hypotonia during infancy, that stands out. Often patients with autism have a normal early period, and the issues are regarded later. So is this an early presentation of disease? The fasting intolerance, that patient needs to eat very regularly and may have difficulty in the morning if they don't eat right away. Classically, with autism, autistic regressions happen before 2 or 3 years, but here is a patient who is continuing to regress with illnesses after that period, up until at least 5 years of age. But then the skills come back, so there seems to be this prolonged recovery time. And then the mild diffuse hypotonia that is noted on exam, and he looks tired, but that may be situational for that time. So again, those are the things that stand out for me that is not typical for autism and I would pay attention to. So this would prompt a bigger review of systems, because my concern is in a patient who fatigues easily and had onset of motor concerns from early infancy. Given the association between autism and energy disorders, my concern would be a mitochondrial problem. And so, again, I would do a bigger review of systems to see if there is involvement of other systems, which would increase my concern further. Patients with mitochondrial disease, in addition to the fatigability, some of those patients do have problems with fasting intolerance, because you need your You need your mitochondria to break down fat and use them as a source of energy, and that might be impaired in some patients with mitochondrial disease. The classic regression after illnesses and prolonged recovery time is pretty typical for mitochondrial disease.
So how would you work up this child from a diagnostic point of view, given that there is some concern about a disturbance of energy homeostasis?
Do we have another hour? Okay.
What would be your first line of things?
All right. So the first thing that I would do, in addition to the review of systems and do a family history, is I guess I would do some labs to assess to see whether there's any other indicators of mitochondrial dysfunction. So in blood, I would do, as mentioned before, a blood lactate, a blood pyruvate, a blood amino acid profile. I would look at carnitine and blood acylcarnitines. I would probably look at transaminases and bilirubin to just check liver function. I would do a CK level to assess muscle. And I would get urine for organic acids. As a profile, I would also have someone look at the child's eyes, because you can find specific eye findings in mitochondrial disease, and I would just make sure the child's hearing is normal. And that would probably be my first line of investigation, it's sort of a, if you will, an organ inventory just to make sure there's no other organ involvement.
And then the follow-up would be predicated on the results of that first round.
That is correct. Again, other possibilities in the differential diagnosis, again, fatigability and exercise intolerance in this setting, I think it'll become more obvious over time, as in the first case, that this patient has an energy problem. But I would consider a fatty acid oxidation problem. I would consider possible evidence of some sort of glycogen storage problem to account for the fatigability and the exercise intolerance. I would be concerned about a carnitine problem, but these suggestions I'm giving you aren't necessarily associated with autism. So it becomes something in the history is going to have to give if we're going to include a lot of other things in the differential. So I would probably start with that, and if those are all negative, expand my differential diagnosis too.
Well, this is wonderful to hear from an expert like you dealing with these important cases, because certainly not all kids and adults with autism have a very stereotypical, narrow clinical story. Many of them do have GI concerns, cardiac concerns, skin concerns, or constitutional complaints.
Also, what I would say is, especially in a child with autism and a child who fatigues, one should make absolutely sure that the diet is well balanced, because inadequate intake of certain vitamins and minerals could bring its own level or bring their own symptoms, which could include fatigue, which include lack of attention, and could complicate the phenotype. So especially in a child with autism, if there's a finicky diet involved, a good nutritional assessment is important.